Nephrology is complex. It studies the body at some of its most complicated intersections of physiology and human health. This podcast, ASN NephWatch, will try to identify how events in modern society help, hinder, or have no effect on the march towards better care and cures for patients with kidney diseases, the challenges clinicians and researchers face to improving the lives of these patients. Thank you for joining us here at the Washington headquarters of the American Society of Nephrology. This is ASN NephWatch. We're joined today by Dr. Sue Quagan from Northwestern University, who is also a member of the ASN Council. Welcome, Dr. Quagan.
Yeah, thank you, David. It's great to be here.
Okay, you are the co-chair of the ASN Innovation and Discovery Task Force, is that correct?
Yes, that's right.
And what's the big picture goal there?
So the task force is charged with coming up with some big ideas to catalyze discovery and innovation in the renal space. And the goal of the task force, or the task force actually is made up of a number of big thinkers in nephrology, but also a number of exceptional minds from outside nephrology. And today we're here with a think tank really trying to get some of those ideas and putting them down on paper.
So you're bringing in thought leaders from other disciplines, and but all within medicine, correct? Or not?
Well, not all within medicine. So the idea of the task force was really to think outside the box, come up with some big ideas that are going to change the path of nephrology. So many of these individuals are in medicine, but some are basic scientists, some are in pharma, some are in small biotech, some sit in the government, others have research labs. Most of them were chosen because of their ability or their past demonstration of innovating in other areas. And we're trying to bring some of those ideas today into the renal space.
I know you guys have spent a lot of time discussing challenges and you're moving on from that stage alone, but just for real quick for our listeners, kind of where do you see you're coming from in terms of the landscape?
So, when we think about innovation in the renal space, yes, there have been challenges, and there still are some challenges in bringing those discoveries into the clinic. However, I would say that over the past few years, the number of advances in the basic science and understanding of the pathogenesis of disease now place us or poise us in the perfect position to take those discoveries to the next phase. And so our job here today at the task force is to come up with some big ideas, put them down on paper, and they will be presented to ASN Council. And the hope is that we will act on some of those things and really catalyze discovery and innovation and make some changes for our patients. The task force will come up with this list, and that will be presented to Council in February in 2018, so not too long.
Okay, so would you be willing to come back and speak to our listeners again and let them know how this goes?
Oh, yes.
Okay, we are very lucky to have with us today Dr. Roy Chaudhry, and he is with the University of Arizona. Welcome.
Thank you.
Can you tell us a little bit about what you're working on today?
Right, so one of the things that we're trying to do within this task force is really to get together a very diverse group of people, clinicians, researchers, people involved in policy. I think perhaps most importantly, in addition to people who are in the kidney space, we also have a number of people who are scientists and clinicians from outside of the kidney space. And I really think that bringing together all of these different ideas is going to allow us to come out with something that I hope will be both impactful, will be patient-centric, and will also be disruptive. I think we really need to change the status quo that we currently have within kidney disease. We live in a world where we do not have effective therapies for preventing the progression of chronic kidney disease into dialysis. And when patients' kidneys fail, we say that you're going to go on to dialysis or hopefully get a transplant, and we feel that that's a big plus. I would argue that we need to be in a place where we have better awareness of kidney disease. We need to be in a place where we can have a pill that prevents progression of kidney disease in the vast majority of patients. I would love to be in a place where we have lots and lots of ads on TV about all of these wonderful therapies that our patients need to ask their doctors about. But I don't remember a single ad which says, speak to your doctor about this new therapy for the prevention of kidney disease. I think to some extent, kidney disease is not like having a heart attack. So you don't clutch your heart in the middle of a road and you don't fall down. Kidney disease is not a young woman having breast cancer or a child having a terrible condition. And I say that really to I think, recognize and applaud all of these different specialties like oncology, for example, where there's been tremendous progress. I rather bring them up just to make the point that kidney disease is silent, kidney disease is insidious, kidney disease is associated with many other comorbid conditions. And I think the tragedy really is that by the time our patients reach end-stage renal disease, they've undergone 20 years of diabetes or hypertension. Kidney disease disproportionately strikes ethnic minorities and people who are more vulnerable to the negative effects of a chronic disease. All chronic diseases, I think, drive people into poverty, but I think the impact is even more when you have a chronic disease that disproportionately targets vulnerable populations. I think that kidney disease is a multidisciplinary problem. I think the only way that we're truly going to be effective at targeting kidney disease is through a multidisciplinary approach. And when I talk about a multidisciplinary approach, I'm talking about healthcare professionals, physicians, researchers, scientists. I'm talking about, very importantly, patients and patient organizations. I'm talking about industry, large pharma, small biotech, dialysis organizations. I'm talking about federal agencies as in the FDA, the NIH, CDC, and CMS. And I think that all of these different stakeholder groups need to come together. I think they need to coalesce around a common plan. And I think that we need to reach out to people both in and outside of the kidney community to allow for this plan to go forward. At the end of the day, I would like patients to know they have kidney disease. I'd like to have a pill that prevents progression of kidney disease. And if that pill doesn't work in every patient, I'd like to be in a setting where instead of having this 4 hours, 3 times a week construct, that we really move aggressively towards portable, wearable, and ultimately a fully implantable kidney so that our patients can actually continue to work, continue to have a good quality of life. I think it's also important for practicing nephrologists to give hope to their patients. I think it's very important in the kidney disease field for there to be hope. And I think that many of the things that we're trying to do within this task force will ultimately, I think, give hope to patients and give confidence and enthusiasm both to nephrologists and to our industry partners.
Thank you very much for joining us today.
Thank you.
Our listeners, we have Dr. Laura Benjamin, and she's from Katahdin RX. Is that correct?
That's correct.
A little bit about yourself and your role in the ASN Innovation and Discovery Task Force.
My background is both academic as well as industry. So I was a researcher at Harvard Medical School for 10 years, and my area of interest there was in vascular biology. Vascular biology touches on many diseases, so it's an important area for renal disease. Probably more of my effort went into oncology, and certainly in the pharmaceutical space where I've been for the last almost decade. I've been focusing on oncology. But nonetheless, I think that what I can bring to the conversation today is sort of a general knowledge of the science that could be applied to renal diseases, as well as sort of industry experience and how do you take ideas and academic knowledge and translate them into new medicines. Oncology has been an area with a lot of success in the last decade, and so one of the conversations that we're having today is, well, what can we learn from how oncology made this big leap forward in the last decade that could be applied to renal disease?
I think all of our listeners would actually like to hear a little snippet of that.
Well, so one of the one of the analogies that I can make for that is when people say, I have lung cancer, or someone I know has lung cancer. I think we've learned through education that lung cancer is not a single disease, it's many diseases, and we've been able to learn how to separate those individuals that are members of these small diseases because of the research efforts into the genetics of lung cancer, for example, as well as the pathology and physiology. But what we've done in cancer is take what was otherwise a broad disease and break it into smaller subsets. And once we're able to identify the smaller subsets, we're able to study it in a more direct way. We're able to develop drugs that are more useful, because we have drugs that treat 5% of patients with lung cancer and don't treat the rest. And if we didn't understand how to pull those patients out, all of the trials would fail, because 5% of the clinical trial having a successful response is not enough to get an FDA approval. You only see the success when you can identify and name the subsets of the disease. And you could say the same is true for something like chronic kidney disease. It's a heterogeneous population. We know that it's heterogeneous, but what we don't know is what we know already in lung cancer. We don't know how to find those subsets and what defines those subsets and what are the kinds of therapeutics that would treat those subsets. And so one of the first things that has to be done for this disease is some of that groundwork.
How do you just kind of view the renal space right now in terms of this challenge?
I think the renal space is challenged in part because renal disease can be a part of many different diseases. It can be subsets of very defined, bigger populations, and therefore I think it tends to get underserved. I don't want to say ignored, but certainly not given the attention that diabetes as a whole gets, both from the research and from the public awareness and from the drug discovery, drug development. And so when you look at the clinical space right now in terms of what's going on in clinical trials in renal disease, it's almost nothing. It's really sad. The NIDDK at the NIH clearly understands this already. I think what could really help would be a little bit of a grassroots effort to collect information about this heterogeneous disease and understand more about the biomarkers and the clinical parameters that are associated with them, and think about doing observational clinical trials.
Continuing our discussion with the ASN Innovation and Discovery Task Force, we're joined by Dr. Culleton. Tell us about yourself and your background. You're a nephrologist, correct?
Yeah, I'm a nephrologist that was trained in Canada. I did some research in the Boston area. I practiced in Canada for about 10 years. And then after looking after patients and doing some clinical research, I decided to move to industry. And for the last 12 years or so of my career, I've been working in the kidney space, developing and testing and developing new technology for patients on dialysis.
And where do you see kind of breakthroughs happening or coming along the way?
So I think one of the challenges within the dialysis space is that there hasn't been any significant innovation over the last 15 to 20 years. We now need to make the technology a little bit safer, easier to use, but I think the real innovation is going to occur in the service model.
Okay. Tell us more, please.
We've seen this in other countries, but the U.S. is a little bit behind. But the innovation, I think, needs to move in the direction of how do patients take more control of their lives, play a bigger role in their decision, and can we bring dialysis closer to their home?
Why do you think it is that we have lagged behind other countries in that regard?
So why has the U.S. lagged behind in that regard? That's a bit of a loaded question. I think one of the reasons why the U.S. has lagged behind in independent dialysis care is the incentive structures that are in place today around providing dialysis. Quite frankly, they encourage most dialysis to be occurring in very efficient in-center dialysis. Big, like the moonshot, if you like, something like growing a kidney in a dish. That is innovation, but if we just focused our efforts on that moonshot, if you like, we may never get there, and we may miss many opportunities along the way to make a difference. So from my perspective, and I think from what I hear from several task members, is that we should be thinking about early-term innovation, mid-term goals, while not forgetting that moonshot, and not forgetting that we need to keep our eye on perhaps some really disruptive innovation that could change the lives of patients with kidney failure.
You're the second person we've talked to who's used the word disruptive. How do you see the word disruptive?
Yeah, so a lot of innovation that we that we deal with every day is incremental innovation. A disruptive technology would be something that truly is novel and obviously something that adds value to either patients or the health system, right? So
Well,
so just as an example,
Yeah.
we've got X number of people sitting around the room today. We're a tiny proportion of people that are interested in this.
Well, thank you very much for spending time with us today.
Sure, it's my pleasure. Thank you.
Welcome, Dr. Karamanche. We are pleased that you could join us, and our listeners would like to know a little bit about you. If you don't mind telling us a little bit about yourself.
My name is Ananta Karamanche. I'm a professor of medicine at Harvard Medical School and a nephrologist at the Beth Israel Deaconess Medical Center. I spent most of my time doing research. I'm primarily a vascular biologist. I'm interested in studying problems with the kidney that affect the kidney vasculature. An area of expertise for me is preeclampsia, which is a kidney disease that occurs in pregnant women, where these pregnant women present with blood pressure and proteinuria.
So innovation and discovery has been pretty much front and center in your career, wouldn't you say?
Absolutely. I'm the chair of this task force with Sue Quaggan, who's my co-chair, and she's a representative of the ASN Council.
This is going to be an interesting time. Tell us a little bit more about it.
Yeah, so I think the idea behind is to find out, what are the gaps in research approaches that slow discovery and innovation in nephrology. It's a wide sort of range of topics, all the way ranging from, how the way we can get the next generation of scientists to how can we help the existing, renal scientists to come up with new drugs, but also more importantly, how can we incentivize companies to develop the next generation products in this space and basically get nephrology excited. As I recall in the 70s, as we were getting new dialysis machines and kidney transplantation was getting started with a lot of new drugs, nephrology was very exciting. And now, after the last, I would say 10, 15 years or so, a significant portion of the excitement in medicine is largely in oncology, in terms of research. The question is, can we get nephrology, excited again? Can we get new products for our patients? And eventually that'll trickle it down to our students and residents. Can we get the best students and residents into our specialty? And so the idea is that, what can we do, people from, different fields, from industry, from academic side, from policy side, what can the ASN, do? Can we put together, people from different backgrounds, come up with ideas about what are the current gaps and how can we spur innovation in nephrology? And so it's a broad topic, but I thought it was we brought a lot of, interesting people from different backgrounds and really had a very productive day.
Well, great. That is a very large order, and we hear a lot of nephrologists talking about the need for new innovation and the need for some level of excitement in the field. That's a hard thing, though, to kind of make happen naturally, excitement.
Yeah, absolutely. I think that, people see on the newspaper, new drugs for cancer, and cancer, which used to be a terrible disease, finally, people are starting to come up with therapies that can even, people are even thinking of cure certain types of cancers. There are certain immune drugs, in a percentage of patients are even curing people. And so there's a lot of excitement in oncology, as I can see. The idea is that, what can we do? Young students and residents, for example, look at that kind of stuff and they go into oncology. And the question that we're asking is that, what can we do in renal to get young people excited? And so one of the things that the task force thought was very important was that, I think ASN as an organization of physicians should celebrate some recently achieved major sort of, kidney breakthrough and sort of advertise that and take credit for some of the big stuff that's occurred. And, nephrologists tend to be sort of relatively modest, I think. But the fact is that in the last, 10, 20 years, we've had some, impressive breakthroughs by nephrologists, trying to understand oxygen sensing, for example, in the kidney that has led to new ways of treating anemia. That doesn't require actually giving back the hormone, but just a pill that blocks, for example, the enzyme that regulates erythropoietin, production from the kidney. We're looking at new ways of slowing down, diabetic nephropathy. It's a transporter that essentially is important for glucose absorption in the tubule, and essentially you can think of a compound now that's FDA approved for diabetic patients that essentially pees out the glucose in the urine. And just simply doing that, you can slow down progression of diabetic kidney disease. And more recently, I think, for example, nephrologists put together this large consortium of scientists, around the country to do this trial called SPRINT trial. Really showed that if you treat hypertensive patients, elderly hypertension patients, that the tighter control of blood pressure led to better outcomes. And so these patients had less strokes and less cardiovascular disease. I think it's very exciting. I think the fact that the ASN recognizes that there's a problem in nephrology. We're not getting the top pharmaceutical companies to develop drugs in our space. They recognize that. So I think having this sort of dialogues, having this communication with people with different backgrounds and trying to see if we can do something, I think, they'll have some immediate benefits, some small things like, for example, getting a renal fellow to do a sabbatical in industry for 6 months. Those kind of things you can see immediate success, but there'll be things that'll take 5-10 years to sort of figure it out. But I think in the long run, I do think that, good things are going to come out of this for the field.
Well, thank you very much for joining us today. I know our listeners have really enjoyed hearing from you.
Yes, thank you very much.
Thank you. Thank you for joining us for a look inside innovation and discovery here at ASN NephWatch. This podcast is copyrighted by the American Society of Nephrology, all rights reserved. All content in this podcast is for informational purposes only and is not intended to be medical advice. This podcast should not be used in a medical emergency or for the diagnosis or treatment of any medical condition. Please consult your doctor or other qualified healthcare provider if you have any questions about any medical condition or before taking any drugs, changing your diet, or commencing or discontinuing any course of treatment. Thank you for listening to this podcast of the American Society of Nephrology.